Audio course on intrahepatic cholestasis of pregnancy, Episode 6, Bedside Management and Postpartum Follow-up. This episode is based on the Israeli ICP position paper, Gabe's Hepatic Disease and Fetal Surveillance chapters, Ovadia 2019, and the SMFM consult. This final episode turns the course into a bedside algorithm. The algorithm is not a checklist to memorize. It is a sequence of clinical reasoning. Diagnose the pattern, stratify by bile acids, treat symptoms, monitor honestly, time delivery by peak risk, confirm resolution. Let us walk through that sequence. Step 1. Suspect ICP. The patient is usually in the late second trimester or third trimester. She has pruritus without a primary rash, often palms and soles, often worse at night. Ask about prior ICP, family history, multifetal pregnancy, IVF, hepatobiliary disease, gallstones, medications, and previous liver disease. At the same time, check for clues against uncomplicated ICP: blood pressure, headache, visual symptoms, epigastric pain, right upper quadrant pain, fever, vomiting, jaundice, rash morphology, medication exposure. These are not administrative questions. They decide whether this is ICP or a mimic. Step 2. Send the right tests.
The core tests are total bile acids and AST and ALT, and bilirubin. Interpret alkaline phosphatase cautiously because it normally rises in pregnancy. If the case is severe, jaundiced, painful, hypertensive, systemically ill, or atypical, add platelets, creatinine, urine protein assessment, coagulation studies, viral testing, and imaging as clinically indicated. If bile acids are above 10 micromoles per liter in a symptomatic patient, the diagnosis is supported. If they are normal, but the symptoms are classic and persistent, repeat bile acids and transaminases. Do not close the case too early. Step 3. Classify by peak bile acids. This is where residents must be disciplined. Do not classify by itch severity. Do not classify by ALT. Do not classify by how anxious the room feels. Use peak total bile acids. Below 40 is the lower risk group. 40 to 99 changes the tempo and moves delivery earlier. 100 or higher changes the risk conversation. Remember the Ovadia numbers. In singleton pregnancies, stillbirth prevalence was about 0.13% below 40, 0.28% from 40 to 99, and 3.44% at 100 or higher. Step 4. Treat the mother. Start ursodeoxycholic acid, or UDCA, for maternal symptoms. A practical starting approach is 10 to 15 milligrams per kilogram per day in divided doses. The Israeli paper gives 300 milligrams 3 to 4 times daily. If needed, titrate up to 21 milligrams per kilogram per day. Tell the patient what to expect. Itch may improve in 1 to 2 weeks. Labs may improve in 3 to 4 weeks. Also, tell her what not to expect. UDCA is not proven to prevent stillbirth, and it does not replace delivery planning. If symptoms are refractory, reassess the diagnosis, optimize UDCA, and involve maternal fetal medicine. Consider rifampin or rifampicin as an add-on in selected refractory cases. Consider cholestyramine when appropriate, but remember gastrointestinal effects and vitamin K absorption. Consider S-adenosylmethionine as a less central adjunct. Use antihistamines for sleep, not as disease treatment. Check coagulation or vitamin K status when jaundice, steatorrhea, cholestyramine use, or bleeding risk makes it relevant. Step 5. Monitor honestly. The Israeli position paper says continued maternal fetal medicine follow-up is recommended, including fetal heart monitoring by gestational age and ultrasound follow-up. It also states that no monitoring strategy or hospitalization has been proven to prevent sudden fetal death, and that monitoring frequency is left to clinical discretion. Maternal monitoring also matters. The Israeli paper notes an increased incidence of preeclampsia in women with cholestasis, often beginning 2 to 4 weeks after the ICP diagnosis. So follow-up is not only fetal monitoring and bile acids, it is also blood pressure, symptoms, platelets and liver tests when clinically indicated, and vigilance for a second disease process.
SMFM suggests beginning antenatal fetal surveillance when the gestational age is one at which an abnormal result would lead to delivery, or at diagnosis if diagnosis occurs later. GAB's fetal surveillance chapter lists weekly modified BPP from 34 weeks, while older hepatic chapter language mentions twice-weekly NST as reasonable. But the most important teaching is not the exact frequency. The most important teaching is humility. ICP stillbirth may be sudden. It may occur after reassuring testing. It is not usually preceded by growth restriction, oligohydramnios, or classic chronic placental histology. So use surveillance, but do not let surveillance become false reassurance. A normal NST does not erase bile acids of 120. Step 6. Plan delivery. Under Israeli guidance, use the highest measured bile acid level. If peak bile acids are below 40, deliver at 37 plus 0 to 38 plus 6. If peak bile acids are 40 to 99, deliver at 36 plus 0 to 37 plus 0. If peak bile acids are above 100, deliver at 34 plus 0 to 36 plus 0. Delivery at 34 to 36 weeks can also be considered with elevated bile acids plus pruritus unresponsive to treatment, prior fetal death at an earlier gestational age in ICP, or departmental discretion. Under SMFM, bile acids below 100 are delivered between 36 plus 0 and 39 plus 0, with below 40 toward the later end, and 40 to 99 earlier. Bile acids at or above 100 are offered delivery at 36 plus 0. Delivery between 34 and 36 weeks is reserved for 100 or higher disease, with special high-risk features, such as excruciating refractory pruritus, prior early ICP stillbirth, or worsening hepatic disease. Before delivery before 37 weeks, give antenatal corticosteroids if not already given, and if appropriate. Counsel explicitly about prematurity. The decision is not bile acids alone. It is bile acids plus gestational age, symptoms, prior history, comorbidities, fetal status, local policy, and patient values. Step 7. Manage labor with awareness of fetal risk. ICP is associated with meconium-stained fluid and fetal heart rate abnormalities. SMFM recommends continuous fetal monitoring during labor. This does not mean every patient needs cesarean delivery. It means intrapartum fetal status matters, and the team should not treat the labor as low risk. Step 8. Follow postpartum resolution. Delivery usually produces rapid improvement. Gabby states that delivery rapidly and completely relieves cholestasis in typical cases, but do not forget the postpartum check. If pruritus persists for 4 to 6 weeks after delivery, or if liver tests remain abnormal, SMFM recommends repeat biochemical testing and referral to a liver specialist if abnormalities persist. That is because pregnancy may have revealed underlying hepatobiliary disease rather than creating the entire problem. Counsel about recurrence. The Israeli position paper reports recurrence up to 90%, often earlier in later pregnancies. GAB reports recurrence around 2/3. Either way, recurrence risk is high. In a future pregnancy, early pruritus deserves prompt bile acids and transaminases. Also counsel about hepatobiliary morbidity. ICP is pregnancy limited in the usual case, but it is also a marker that the hepatobiliary system may be vulnerable. Now, let us finish the course with 5 clinical cases. Case 1. 30 weeks, classic itching, bile acids 8. Not confirmed. Repeat bile acids and AST and ALT if symptoms persist. Consider empiric symptom treatment if severe,
But understand that starting UDCA before labs return can make biochemical confirmation harder. Case 2, 32 weeks, bile acids 26. Confirmed ICP. Treat symptoms, repeat labs, follow, and do not deliver yet solely because ICP exists. Case 3, 35 weeks, bile acids 58. This is the 40 to 99 group. Under local Israeli guidance, plan delivery 36 plus 0 to 37 plus 0. Give steroids if delivering before 37 and not already administered.
Case 4, 35 weeks, bile acids 130, severe pruritus despite medication. High-risk disease. Local Israeli guidance supports delivery from 34 to 36 weeks. SMFM supports 36 plus 0 generally, with 34 to 36 considered when severe refractory symptoms or other high-risk features are present. This is an MFM level conversation. Case 5. Postpartum. Still itching at 6 weeks. ALT still elevated. Do not call this lingering ICP and move on. Repeat labs and refer for hepatobiliary evaluation. Now, final synthesis of the whole course. First, ICP is a pattern: late pregnancy itching, usually no primary rash, and elevated bile acids. Second, the differential diagnosis matters. ICP is uncomfortable for the mother, but its mimics can be maternal emergencies. Third, fetal risk is bile acid driven. Peak total bile acids are more important than ALT or itch severity. Fourth, the thresholds are 10, 40, and 100. 10 names it. 40 changes the tempo. 100 changes the risk conversation. Fifth, UDCA treats maternal symptoms in labs. It is not proven stillbirth prevention. Sixth, surveillance is useful but imperfect. It should include maternal vigilance as well as fetal testing, because preeclampsia can appear after ICP diagnosis. Seventh, delivery timing is the central fetal risk intervention. The final memory sentence is this: the itch brings her to you. The bile acids stratify the fetus. The peak value times the delivery. And postpartum resolution confirms the diagnosis. End of episode 6.